Our next speaker is Dr. Menon regarding revascularization and cardiogenic shock, residual syntax score, and CTOs.
Thanks so much. Residual syntax score is strongly associated with outcomes in patients with stable coronary artery disease and acute coronary syndromes. The question here is, what is its importance in the setting of cardiogenic shock? And I think that's very relevant because, as you can see, when we did the shock trial back in the mid-90s, when you see patients with acute myocardial infarction in shock, predominantly patients have triple vessel and double vessel disease, and there's very few single vessel diseases scattered in there. So the question of what's happening in the remote ischemic zone has always been extremely relevant. And what's equally intriguing is that when we look at the early revascularization arm of the shock trial, we gave the investigator the opportunity to either consider CABG or PCI in this setting. Remember, this was the mid-1990s. All we had was balloon angioplasty. There was minimal use of stents in the shock trial. And so all the left main disease patients and the severe triple vessel disease patients went for bypass surgery. And shown here is a look at what happened based on the revascularization strategy. And you can see that patients with CABG did pretty well, despite being sicker and having more extensive disease. And so this does raise the question, is it important to achieve complete revascularization as CABG can in this setting? And is this benefit due to more complete revascularization with a CABG strategy? Now, in contrast, the clinical trial that was done and done extremely well by Holger Thiel, you saw the culprit MI study, really suggested that multi-vessel intervention had no role in acute myocardial infarction complicated by shock. In fact, the outcomes were worse. But I think I want to highlight your attention to this sub-study from the culprit shock trial that was published in JACC last year. And this actually shows you what the residual syntax score was like and what its impact was on the culprit shock trial. So the first thing to notice here is that patients with shock have a very high syntax score because they have complex multi-vessel disease. The second thing you can see is after doing PCI, whether in a multi-vessel approach or with a deferred approach, the amount of residual ischemia, or let me say residual anatomical disease, remains fairly high in this population. Shown here is what the impact of the residual syntax score is and the baseline syntax score. So you can see these two curves in blue and red. You can see that as the baseline syntax score increases, the residual syntax score increases. However, what's really important to see is that the residual syntax score is completely not impacted by the initial strategy. So you would have expected that the residual coronary risk score would be lower in the multi-vessel group, but in fact, it's not. So even when an interventionalist intends to perform multi-vessel intervention in the setting of cardiogenic shock, that is impeded by the kind of anatomy and their failure to perform complete revascularization in this setting. And so residual coronary risk or residual risk score is more, to me, a surrogate for the kind of disease rather than the strategy to be employed. However, it is very impactful. When you look at the residual risk score and you look at outcomes, residual risk is strongly associated with poorer outcomes. And this does raise a hypothetical question as to whether we should be using mechanical devices and other supportive devices to do more complex remote revascularization in this setting. Clearly, this is an association, but the hypothesis there would be if you lower the residual risk score, you will improve outcomes, but that is not yet proven, and currently we work on the culprit artery alone. And here, again, I'm showing you the impact of the residual coronary risk score on outcomes, and you can see the worse the residual risk score, the worse the 30-day mortality, and then the curves are relatively flat going forwards from 30 days to 365 days. So let me put things as an example. So here's somebody who comes in, 60 years old, chest pain, acute infarction, they're in sinus tachycardia, they've got a right bundle branch block and a left anterior hemiblock. There's acute ST elevation in the anterior precordial leads. What really concerns me is that PR prolongation that you see in this setting. They get taken for coronary angiography, and you can see diffuse disease in the right coronary artery, but really no flow-limiting lesion. And then when you look on the left side, you can see an ugly circumflex vessel with really poor flow, and then you see a compromised LAD. So I think obviously each one of us is going to do the LAD and open it up. The question is, should we open the circumflex? And I think what the culprit shock trial and other trials don't do is they don't look at what is the myocardium in the non-infarct zone. Is it ischemic? Is it normal? Is it scarred? I mean, one would submit that if one had a wafer-thin inferior wall, one wouldn't open up a right coronary artery in that setting. And here you can see, despite the severe disease in that circumflex distribution, I see an anteroapical wall motion abnormality, but the circumflex is going gangbusters. So at least in my mind, once I open up that LAD from an acute setting, there wasn't any mitral regurgitation. I'm not going to spend extra time, extra dye, trying to open up that circumflex in this setting. On the other hand, if this person had severe hypokinesis in that wall, perhaps I would have considered that. And I do think that kind of clinical judgment needs to be replicated in clinical trials. So in this case, the LAD was wired and ballooned, and then subsequently stented. I brought this up just for the fellows. You had to expect that based on the EKG. You see second-degree AV block in the setting of that LAD infarction. You should suspect that in the setting of PR prolongation. The conduction system is impaired in the setting of an anterior wall MI. You need to be prepared to put a wire very quickly in this patient, which was done. And then the patient was subsequently did fairly well after the LAD intervention and was stable. So in terms of summary, residual syntax score appears to be related to baseline findings and not the intended revascularization strategy currently. The residual syntax score is associated with 30-day and 1-year mortality in shock. There is no data yet confirming that a targeted strategy to achieve complete revascularization in shock will improve outcomes. It does raise the question whether we should wake up our friendly surgeon who plays no role in our current management of CABG in the absence of mechanical complications and revisit the role of bypass surgery in acute myocardial infarction complicated by shock. Thank you.
Venu, you beg for a study to answer the question, but your take home, as I get it, is do the very best you can with what the anatomy has handed you. So how are you going to design a study with that?
Say it again.
Okay. You asked for a study to answer the question.
So obviously, I think the reason why the interventionist is not opening the other vessels is, one, the tools, two, the kind of support. If they had more mechanical support and they used more upfront mechanical support, they may be braver to do more intervention. There's a study called the CABG shock trial that's being designed right now to achieve complete revascularization in these territories. And so there are multiple ways to further improve and decrease the score. Now, is the score just a pretty picture that you're making look better, or is that going to impact on outcome? That data is completely uncertain at this time.
Well, we have to kind of go back in circles. I mean, it's good in the sense that, you know, years ago, and I'm talking 25 years plus, we were always taught that you would, you know, while surgery was an option, you weren't running to the OR because the outcomes were poor, you know, in that setting. Then angioplasty, stents, everything else came and we lived through this, and then we've gone through these trials, we established lesion severity based on syntax. But to your point, I mean, it's an anatomic variable, it's not necessarily a physiologic variable. So I would ask you, it's tricky to define the trial. B, how about the role of, we went through this whole business with FIRE and FFR, and using that as a marker in terms of the bed and the perfusion bed. To use that, you showed echo. I mean, what are your thoughts about using that as a modality?
Yeah, I think you certainly could use it. I think the criticism for the culprit shock trial was that there were CTOs there, and the mandate was to even try to open up CTOs. So 50% of these were CTOs that we would not open in an elective setting unless people had angina and ischemia that we were then using on a patient who was already vulnerable. So I think the jury's still out there as to whether this is a worthwhile strategy to pursue.
It seemed to me that the trial asked the question, should all of the revascularization be done acutely, or can you do the culprit only and then bring them back for staged PCI? And so the attempt at a comprehensive revascularization for all patients in cardiogenic shock was recommended within the trial. So I think it gives us a little more breathing room to just get to the culprit and then tackle the issue of comprehensive.
Yeah, no, I feel perfectly comfortable with this, but I think what this trial, what is the takeaway point here is that you had patients randomized, and the interventionist went in with the intent to perform multi-vessel intervention. So they were more aggressive. They were looking at the infarct zone, and they were looking at the non-infarct zone. In the other arm, they were looking at the infarct zone alone. Yet, when an angiographic core lab looks at the data downstream, the amount of myocardium that was left, or the amount of coronary anatomy that was unrevascularized, was actually higher in the arm that you were dedicated to performing multi-vessel intervention in. So I think that paradox tells you that there is more to the story than just doing PCI.
On that note, since there is a lot more, this could be a very juicy conversation. We're going to thank you so we can keep ourselves on time. I want to